Welcome back. Rita is one of our stars, one of our nurses who knows what it is to walk this walk along with us all. We're really proud to have her be part of our team. So thank you, Rita, for sharing your feelings, and great way to get us kicked off this morning. So let us begin our first session. And as you can see, I am your humble moderator, but we have folks here who are the real pros in all of this. And basically what I've asked them to do is in turn is to actually introduce themselves. You can see their titles and their role in this, but starting with Dr. Smoot, then Laura, then Craig, just give us a little bit of introduction of who you are, why you're here, and what's the biggest things that you think are a problem. And before I let you have the microphone, the background on this, and for me, it's really taken the sort of George Floyd moments to wake up to this, is that if I look at Washington, D.C., just my catchment area, and as the senior GI oncologist in this city, and I look at just where you live, and to some degree what color your skin is, although it's probably more around economics, in my opinion, than race and ethnicity, but we can talk about that. That's one of the things we want to talk about this morning. But you have a different survival from colon cancer, a dramatically different one. I sort of think of it as the haves and the have-nots. And this is not just insurance. These are all insured people. But if one thinks about access to cancer care, what it takes to get cancer care, the understanding of the medical community and managing a multidisciplinary team, and the almost full-time job that it becomes to be a cancer patient, and the village around you that you need in order to optimally support the patient, if you will, whether it's transportation, watching kids, maintaining insurance, having co-pays, managing side effects. All of those things have to be in sync in order to get optimum cancer care. And it doesn't take much to disrupt that network. And some networks are a lot more fragile than others. And so I couldn't imagine a better panel to begin talking about this. And Dr. Smoot, I'm going to have you go first, as I said, with some introductions and some sense of why you care about this and why you chose to join us this morning and what you think are sort of top shelf issues. Then Laura, then Craig.
Well, good morning, everyone. I'm pleased to be here. Dwayne Smoot, I'm a professor at Meharry Medical College and clinical gastroenterologist, and been practicing gastroenterology for many years now. And I've had research interest initially with H. pylori, which causes ulcers, but also is associated with stomach cancer, and more recently with colon cancer. And so my area of interest has been more in relation to screening and gastrointestinal cancers. And so the issues that I'm most concerned and interested in are screening for gastrointestinal cancers. And at the top of the list is, of course, colon cancer and colonoscopies that's actually been shown to be helpful in identifying and reducing some of the mortality that we've seen from colon cancer. Also, esophageal cancers, stomach cancers, not as easily to detect, but people do have symptoms. And what we need is for people to come in to be seen and evaluated. We have excellent procedures, excellent safety records that we can investigate and identify esophageal diseases and cancers early, and identify stomach cancers. Pancreatic cancers are a little more difficult, but we're doing an excellent job, as I mentioned, with colon cancer. So for me, it's about getting people to not be afraid to come in and be seen and evaluated. The concern I hear from people is that if we do a colonoscopy, you'll find colon cancer. So I don't want to have a colonoscopy. Well, you really got to think about that. If you have cancer, whether we look or don't look, you still have cancer. And if we do the colonoscopy, we'll find it early and be able to maybe even remove a benign tumor before it actually turns into cancer. And that would be our objective. So we don't want people to think negatively that if we look, we'll find something. And if we don't look, it's not there. And so we're just trying to educate people, make them more comfortable with the process so that we can continue to increase the screening and be able to reduce mortality and incidence of gastrointestinal cancers.
That's terrific. Laura.
Thank you so much. I am Laura Rozic. I just moved here to Georgetown and am a member of the Lombardi Comprehensive Cancer Center. I'm an epidemiologist, so I am not a physician. I sit with Dr. Smoot and Dr. Marshall and hear them talk, and I'm so impressed by all of the treatments. But my work addresses the racial and socioeconomic disparities that are associated with survival, and in part because survival is a part of our lifetime experiences of the factors that gave us cancer. One of my large NIH-funded projects looks at colorectal cancer in Detroit and the metropolitan areas in Louisiana, where we're collecting African Americans and non-Hispanic whites. And I say collecting, and it sounds so patronizing. What we really do, and one thing I love about being here at Georgetown, and the entire reason I moved here, is we try to take a bi-directional approach to engage people in our studies and understand these factors. To me, some of the factors right now in disparities are twofold, one of which is even outside of cancer and socioeconomic problems, there are vast environmental disparities in our country. These undoubtedly lead to the development of and survival from cancer. And we know people of low socioeconomic status and people of color are much more likely to be exposed to environmental exposures, which is one of the reasons we've targeted our studies to areas in Detroit and Louisiana. And we'll start working here with the members of the community engagement team in DC to ascertain people in our studies to understand that. And also to understand, again, the role of race. Race is important to some part because of the genetics. The underlying genetics we know that differentially give people risk of cancer and survival from cancer. And we also know is associated with data. The United States has done a tremendous job with the Cancer Genome Atlas of looking at variants across different cancer types, but people of color and people of low socioeconomic status are underrepresented. The more we know about cancer, the more we can treat it. And so that leads me to one of the things I think Georgetown really is doing a great job of, and why I'm excited to be here, is this bi-directional component of explaining to people why it's important to be in studies, making it easier for people to be in clinical trials, to be in population studies, so we can really understand the vitally important reasons. And it's hard. I mean, I do this all the time. It took me a long time to get my grant funded, and I heard people of low SES, people of color don't want to be in studies, and I simply don't believe it. I believe the more we educate each other and the more we work together, the more we can really engage people in this important work that, especially in the future, will help people survive better, not only survive longer, but survive better and have better survivorship outcomes. So thank you, Dr. Marshall. I love being at Georgetown. I'm so excited that you asked me to be here today.
We're so excited to have you. Thank you for giving us some Saturday morning time. I know it's precious. So Craig Irving, please chime in.
Hello, hey, good morning. I'm probably the only one who don't have a DR in front of my name. I'm Craig Irving. I live in Alexandria, Virginia. My daytime job is with American Airlines, and on the side I do a lot of advocacy work with PanCan. And I'm here, and I got involved because back in 2013, my sister was diagnosed with pancreatic cancer. And 4 months later, she was gone. And I think one of my commitments to her was that I would stay involved. And although I live in Alexandria, she lived in Mississippi. And one of the most eye-opening facts for me, and you tend to forget when you move away to migrate away from your hometown, is that a lot of small underserved communities, they don't have access. And we had to take my sister 3 hours away from my hometown just to get treatment. And also with the lack of access comes the lack of education. And also, we as a community of people, we're very private when it comes to our health, when it comes to cancer. And a lot of times that prevents us from getting treatment, going to the doctor, sharing what's going on with our bodies just by nature when it comes to cancer. Even myself, I think about for a period of time, my sister was diagnosed. We didn't want anybody to know as if we had done something wrong. And that prevents treatment and can extend the amount of time you're away from treatment. So one of my commitments was, number one, to see how can I do a better job of educating my community in those small rural areas, because a cancer diagnosis in a lot of communities of color is not just about surviving for a life survival. It's about surviving with your livelihoods. A lot of those households are single parent homes. So a cancer diagnosis means I need to make the decision on not just from a life standpoint or what happens to my life at home. I have kids, I have a job, I'm the sole provider. All of those things are factored in. Can I get into a clinical trial? My sister was fortunate; her kids were older, but I kept thinking during the entire time, what if this had been 5 or 10 years earlier? This would have been a totally different situation for my family, because she was the sole provider, and all the resources are not always available there. So when you talk about clinical trial, when you talk about treatments, it's not the same conversation that you will have with someone like me who's in Alexandria, who have tons of resources and facilities around me. It's a lifestyle. It's a life-changing decision you have to make. It's literally making, do I worry about my own life or do I take care of my family? And a lot of times, unfortunate, we go with taking care of the family because you're concerned. We just by nature are just nurturers of the family and think that that's our obligation. So I'm here, and what I've been doing is really, really trying to get the word out in communities where they lack facilities. We turn to the church. Church is a big source of resources for us. We don't have a doctor, but we'll go talk to our pastor, or we'll go talk to the church members. So I found out that's a good way for a good entry point for me. How do I educate the church? How do I get this information in the arms of the church, in the hands of the churches and schools, so they can then get it out and disseminate it to the community? So I really appreciate you guys including me. As I say, no DR in front of my name, but I really appreciate you including me in the conversation.
We are so happy that you have agreed, and I think don't worry about that DR thing. I think in many ways you've got a clearer head about all of this than the rest of us. I promise. Laura, I'm going to be a little unfair and ask you an early question about studying something, a problem like this, versus acting on it. There's always part of me that's like, what are we studying here? Don't we already know what's going on? And is it time for action, or do we still need to really understand more about the problem before we can be efficient in action? Or is there time for both?
And that is the biggest question I struggle with every day I do my research. Before I say this, I feel like I'd be remiss if I didn't say, Craig, you have a doctorate in lived experience. And I love that you're on this, because this is something that I don't know. And I think researchers benefit from designing their questions around lived experience. So I thank you for taking your time to do this. And I do agree, John, I think it's really tough with action. Thinking about when to have action, I would argue that I don't think we've collected enough data. I think that, as someone who's collected data for years and talked to survivors and talked to people who are diagnosed with cancer, it really is biased towards people who have the time to be able to answer these questionnaires. I don't think we understand the impact of how, for example, living near a brownfield, how does that affect both your risk of cancer and survival from, and for long-term survivors, does that affect the way that you've been able to, how your body's been able to respond to cancer therapy? And I think one way that we can move this a little more towards action is to study people in those areas a little bit better, understand the factors, understand at what point we need to make some kind of change to where people live, to how early we screen, how we educate the community on what they need to look for and things that they can do. Because I don't think we've done that well enough. And the fact is, we're not going to be able to eliminate every brownfield. every environmental site. We can't do it, but we can talk to the people in the communities. But I struggle with that and with how to move this into policy. I think more data, and again, I'm an epidemiologist, more data, more data, more data. But that's where I think interacting with people like Craig, trying to bring people in to educate them. I think we're to the point where we can really work with communities much more explicitly to try to come up with good strategies. And I don't think I can do it. I think we need to work with community engagement.
Well, I was thinking about a very famous long-term study called the Nurses Study up from Boston. And for those who don't know what this is, this started, gosh, must be 40 plus years ago, where it's initially women. It's now broader than that, but we're registered to just tell us how your year's gone for year after year after year about life habits and medical issues and the like. And because there are so many people in this set of data, we have been able to learn lots about human health, about interactions, about diet, lifestyle, all sorts of things that have in fact come back to policy. And I think that's part of what we want to talk about a little bit is the need to collect that, the issues around education, participation, trust in participating in something like that. So we'll come to that in just a second, but let's kind of sort this a little bit. And Dwayne, let me start with you on the sort of biology of, GI cancers. And there's a lot of talk, Laura referred to it, about environment, but we also have issues around nutrition. There's the concept of microbiome, which is the bacteria that lives inside it and around us. I'd like to think of it as our own personal little coral reef. Can you talk a little bit about differences that we know today around either nutrition or environment in the large scale and environment on the personal scale, like the microbiome and nutrition, weight, exercise, all of those components that might be factored in and different among these populations?
Yes, those are very good points. We know there's always a good bit of genetics involved, and there are certain genetic mutations or changes that we know are definitely associated with colon cancers, for example, and some of the other cancers, even with hereditary pancreatic cancer. And so we know that that people with those defects, changes, are likely to get cancer at a younger age. But the majority of the GI cancers are later in life and therefore affected by environment. And that's where they had back and forth on more information. So we don't know exactly what genetic change that might be susceptible, but the environment plays a role. Alcohol and tobacco, for example, have been associated with the GI cancers, pancreatic, esophageal, colon cancers, but not everybody who drinks alcohol in excess or smokes are going to get those cancers. So there's obviously some genetics involved in addition to the environment. And so while we need to work to educate people to, again, healthy nutrition, it's has a lot of other benefits in addition to helping to prevent cancer. It's just difficult to be so broad. And that's why I think your first question is a very important one, because we still have to act on what we know, but at the same time, to be more specific, it really helps. And then you bring up the human genome, and that's just, not human genome, the intestinal bacterial microflora. And that is really becoming almost its own field. Yeah. I go to the GI meetings now, and you could almost a meeting inside of a meeting on what happens based on your intestinal flora. And we've only been doing that relatively short period of time compared to everything else.
Let's face it, you and I didn't learn any of that in medical school.
No.
Maybe one afternoon, when
right.
Now it's like, as you say, maybe the most important science, new science that's out there.
Yes. They're just more information that you are what you eat is coming true. And based on, and also because the diet changes so much from day to day, it also complicates things. But there's definite information that certain bacterial flora, intestinal flora, are associated with even heart disease, in addition to potentially colon or intestinal cancers, obviously an intestine is right there adjacent to the flora, but the heart disease is interesting there too. Is it at something that's happening at a distance? So yeah, so we really do need to get some more information to really help guide people and try to be a little more specific in who is going to be more, we need to be more concerned about their nutrition than others based on maybe their genetic profile.
But that also comes back to access. I mean, if you live in a neighborhood that doesn't have, a vegetable stand,
yes,
or the cost of eating healthy is more, we know that, than the cost of eating less healthy, calorie per dollar, if you will. And when you're on a budget and things are tight and you're feeding a lot of mouths, sometimes the recommendations, again, it's just being able to access.
Right.
Laura, what, or anybody want to chime in on that?
Yeah.
Oh, I was involved in a few studies in Detroit, and I certainly know it's true here about food deserts. That even when people want to eat a high fiber, healthy diet, they're forced to eat out of a gas station. And I was really intrigued, and I have to say I'm speaking a little prematurely on the studies that came out this week showing fiber intake. And we know fiber intake is associated with a diverse microbiome in your gut. And Dr. Smoot, I'm sure, knows this. So like the more fiber you eat, you get this like beautiful, diverse microbiome, which is what you want. It's also associated with beneficial responses to chemotherapy. I'm speaking a little bit, I haven't gone through the paper explicitly yet, but it makes sense, doesn't it, Dr. Smoot and all of you, that like, yeah, what you eat is how your body responds to things and can combat environmental exposures, bad things we do to ourselves, which I love doing bad things. I love red meat. I love it when it's charred. So bad for your gut.
Don't say that out loud.
Charred, rare steak. And every time I do that, the little epidemiologist in me is like, oh, it's bad for me. But you eat broccoli with it? Hey, go ahead, Dr. Smoot. You're probably about to say that. Eat some broccoli.
But what's also interesting with the microflora in the gut is also the amount. You eat that big steak, the amount of bacteria actually increases. So it's part of it is the diversity of flora, but also the amount. Same thing if you have a high carb, the bacteria love it, and different bacteria will grow. So while we talk about the diversity and identifying what the flora should be, also is the amount of flora. And just eating a big steak, you just don't know what you're doing by just tripling, quadrupling the amount of bacteria in your gut. And the same thing when you have the big carb meal. So part of that is if you start looking at it, you'll be surprised at how much the amount of bacteria in the gut changes associated with you feeling bad after having that big carb meal, that it go together. So it's just a lot to it.
Yeah, I was going to say from that nurse's study, we learned that exercise, a high fiber diet, vitamin D, maybe aspirin, these sorts of things. And I think what do they have in common? Maybe they're making our microbiome a bit healthier. I'm convinced it's where the soul resides, but I'm a Presbyterian. We can think that. So, Craig, what's your take? I want to kind of shift our gears a little bit around sort of the access, the biases that people have around these kinds of recommendations. From your perspective, what are some of the barriers? We can come out and say all of this till we're blue in the face, but can people live it? Can they walk it?
Yeah. And it was interesting here. You're talking about nutrition and access to those things. And again, I'm guilty of this because I live in a much larger city from where I grew up in. But a lot of time when you're talking about building trust, it is understanding those communities. When you talk about having access to, proper diet, nutrition, really understanding what's available in their community and understanding their life and their lifestyle and their family dynamics. All of those play a part in access and what you're able to do. And another thing, what was hard for me is that I think I said this earlier when we had a conversation, is to make it plain. It can be so intimidating. Number one, just understanding a lot of medical jargon and language can be intimidating, but talking about getting a diagnosis and trying to really figure out what do I do next and what does that mean to me? Make it plain, because there's a strong sense of pride that we have in the community. I'm sure in every community, but there's a strong sense of pride and like there's something wrong with not knowing. When my sister was diagnosed, I had to really tell myself it's okay not to know. It is okay not to know, because unless you find solace in knowing it's okay not to know, you will never open up and ask and try to get a better understanding. So you literally walk away with not knowing what to do next. And as a result of you walking away not knowing what to do, you become overwhelmed, and then you completely just stop trying to get treatment, trying to understand what do I need to do to maneuver my way through these things. So it all ties into building trust. And it all ties into that whole point that I made in the beginning. For us, and for a lot of times in our community, a cancer diagnosis is something that I did wrong. So please don't share it to anybody, keeping it secret. And that can be detrimental. That can be detrimental to actually you getting support, finding out what's available, and actually getting treatment.
Yeah, I think this is a great sort of segue. I mean, we talked about the environment and trying to study it, optimize it, and then get that information out and then enable it. So we know those are some of the issues. And then how does one do that? And those are societal things. Here in the District of Columbia, when there's a new grocery store opened in a food desert, it makes the news, people. I mean, I think we recognize it. There are companies out there that are trying to fix that and try and improve that situation. So there is action in that space. But Craig, what you were talking about is sort of making me go to the next tier, and that is the interface between the healthcare system and the patient and their family and their village, if you will. And Laura, I might pick on you first to sort of talk a little bit around whether it's communication or trust or what's causing that not to be optimum for our patients.
And I work a lot with patients now from the clinical side, but I can tell you in terms of studying and engaging patients in clinical trials, a lot of it from what we were learning was time. I have to underscore also with Craig, a lot of it was we were approaching people in the hospital at the literal worst time in their life, sitting them down and asking them a questionnaire of exactly what they'd done to themselves for 20 years to give themselves cancer. And I can't imagine, I look back on me as a young investigator and I want to go just shake myself and say, you can't treat people like that because they're humans. And one thing that I'm really impressed with that they've done in Detroit and what you do here is engaging with the community, especially engaging with churches and community groups who have knowledge of cancer and knowledge of the studies where people have other places they can go. Detroit runs a really wonderful cohort study called Research on Cancer Survivorship that works with the African American survivorship community, and they go back and give the information through churches and through community events. We're studying, and these are the things that we're finding out. And again, John, you mentioned like the bi-directional working with communities. I think that leads to a level of trust in treating people. Hey, yeah, you may not have a PhD in epidemiology. You're smart. People are smart. They're able to, if you go and talk to people, and you mentioned cohorts too, and NCI, the National Cancer Institute, is putting resources now into developing new cohorts. And a big part that was never in any other call to fund cohorts is a community engagement. How are you going into the community? How are you sharing information? And how are you not walking into a community and taking their data and then walking away and publishing on it without giving anything back? And I think that's incredibly important. So Craig, I mean, I can't say enough about having somebody on you who can sit here and say, yeah, and we're in DC, we're not in Mississippi or rural Louisiana where we have some of our studies. They don't want to talk to us. So what do? We work with the communities and we try to get community members who believe in this and who can work with us to engage people on a level where they can feel trusted.
So I run a fairly big cancer center. So tell me, Dr. Smoot, Dwayne, Craig, tell me what I should be helping when I'm training new doctors, when I'm overseeing our team in general. What are some of the issues that maybe, you would want to tell me aside? How could we do this better in terms of providing, understanding, and bridging? What are some of the things that come to mind?
Well, I would just say Laura already said it. The community engagement. That's where you start. And it's, as you say, it's really being a part of the community. And that's where investigators need to also look. So as you say, in the centers, you write the studies based on what you're seeing in the literature. The question to then come to the community and say, this is what I see as an issue. What do you see as an issue? And the idea is the study really addressing what the community sees, or is it really addressing what was seen in the literature that is apparent that the researchers feel is the bigger issue? And so that is really the big starting point, is really the community engagement, but not, as you say, talking to the community. But we need to get our investigators to also be part of that discussion, to hear what's happening in the community so that we can impact study design that really might be better at getting at the actual questions as you understand what's happening in the community. And that may in part be related to the food deserts, but also how are people adapting to that, and therefore what is actually happening, and would the study actually notice that or be able to power for some of the information you can get from talking with people in the community.
Yeah, Craig, any thought?
Yeah, and make sure, I think what's most important, and I can remember once I had a meltdown with my sister physician, but and the meltdown was surrounded by, make sure you see me as an individual, not just my disease. And I think if you get to see me, then you'll get to understand my situation, realize that we're not a one size fit all. And so I think that goes a long way with building trust, because historically we've had like this personal relationship in our community with our doctor. Use our doctors like a member of the family. So when you branch out from that local small town doctor and start going to specialists, the relationship change. And again, it can be overwhelming. And when we get overwhelmed, we tend to shut down. So I guess the most important part is make sure you see the individual and not just see their disease.
Yeah. So we only have a few more minutes. I knew this was not going to be enough time when we set this up, but we have a couple of questions already in the box. So if any other people want to ask questions, please feel free to put them in. We'll try to get to as many as we can. I want to go to access. So I want to set the stage is that our church is involved with helping a charter school here in the district by providing some extra support for them. And when I asked the principal of that school what the biggest concern that she had, what she was losing sleep over, and it was that kids, and it's a K-8 school, didn't show up for school. You couldn't predict it's their no-show rate. We as physicians know what no-show rates are. So it's their no-show rate. And we were talking about why that would be so. And you talk about families that don't have all the resources, that are living on the edge as it is now. And so that kid might not make it to school because maybe somebody couldn't take them to school that day, or there were and then I think about, well, what if the grandmother was the one who was supposed to take the kid to school, now has colon cancer, right? And so is that grandmother going to make a choice between taking the kid to school, to second grade, or to make their appointment for chemotherapy, for example? And you could see how quickly a web of support could break down if it's not very tightly secured, right? And I think so many of our patients I will say, those who have that network. They have friends who can call up and be that difference, have jobs that they could take a half day off every other week and still get full pay, where there are a lot of people who don't have that kind of job. And so I want to just sort of talk a little bit about that, because that's different that's not a skin color thing. That is an economic network for many, many of our patients. And, what are some of the issues that that come to mind when you think about that, and how we deal with that? Craig, let me go with you.
And I think, hey, John, you made a very good point. And I think the hard part about that, which I've seen many times, growing up, is not that this is happening, is that how do you penetrate to find out? Because it's a big secret, because you work harder not to make sure that the school doesn't find out. Again, there's this really strong need to keep, and I'll say it the way we said, to keep our business in the house. And so as a result of that, this can be going on almost a whole year. And just by happenstance, an educator might find out. But again, I think when you look at working through the church and really trying to see the individual and trying to build the trust, I think that's the easy way that you get in, is building trust.
Others?
So part of my work, besides being in the United States, is I've done a lot of work in global settings, especially I've done a lot of work in Thailand and Southeast Asia. And one thing they have there that the church just always brings me back to is they have a network of community health workers who link people who are private, and they're told, this is your private people who somebody knows they can go to, who link people to services. They link people to get a tuk-tuk from the village to the cancer center. And I know that there's been a lot of success in this in a lot of the breast cancer programs around the country, because breast cancer has a lot of advocacy. And Craig, I'd love to hear from you and Dr. Smoot and Dr. Marshall. It seems to me that a lot of the links here could be done with that kind of like network or help or assistance with people to link them to services, because it sounds to me from the studies I've done, there are services that exist, but navigating that is a full-time job, and having somebody help link, and then tell hospitals, hey, we need Ubers. Like, that's what we need. We need somebody Ubering somebody to an appointment, and that would help. That would be an important part, because the financial toxicity studies I see, people can't do this themselves and keep their jobs.
I mean, what I think our audience needs to appreciate is that outcomes do depend on being on time, doing things efficiently, getting the right molecular test, the genetic testing, being offered a clinical trial means that you're getting state-of-the-art care. You don't have to participate. We'd love you to participate, but you don't have to, but you at least should be in a place where they're offering it to you and be eligible, et cetera. So that's how we'll advance the bar. We only have a couple of minutes, and there are a couple of questions in, and one of them comes back to, doing genetics in different populations. If you look at clinical trials, if you look at the Human Genome Atlas, it is underrepresented in African American and other minority populations. And again, some of that's where these things are done. Some of that's a trust issue and willingness to get them done. Laura, how important do you think that is to make that level that field?
I give an entire lecture on this to epidemiologists, and I've done it at my old institution. I'm sure I'll do it here, because right now it's all power. Dr. Smoot said power. The number of people you have makes it more likely you'll find something. And except for breast cancer, we are underpowered to understand the significance of different genetic variants. We're also 70% of the genetic studies for genetic risk are done in Northern European populations. Yeah. And it's not there. And there is a little bit of trust. I think what we can do as investigators is do the best damn job we can of making sure the data are safe. And I'm pretty confident that we've gotten to the point where we're able to do that.
I'm always amazed that people are like, you can have, Google knows what I'm talking about right now, frankly. So,
did you ever see that cartoon to whisper something into your husband's phone if you want it? I did that last week. I was like, necklace. And then it shows up on his phone. But I think, and again, a lot of community engagement, but a lot of this is also policy. A lot of this is encouragement. It should actually, it's just reprehensible that we haven't engaged this more. I know we're doing in our study, we're doing complete genome sequencing, and we're making it available to people. And I hope we can work with doctors, work with people like Craig to make people understand that when they do this, we'll be as careful with their data and we'll be good stewards of it so they can trust us.
Quick question, Dr. Smoot. Why aren't we screening for stomach cancer?
Oh, I'm sorry, having trouble getting off mute.
No,
yeah, so that's been one that's been discussed back and forth about the rates of stomach cancer in the U.S. are relatively low. So it becomes more of a cost benefit analysis. And so we do evaluate stomachs for potential precursor lesions. And so we are screening some patients and with family histories. And when we biopsy, see some changes that might indicate that a risk. And so it is happening on an individualized basis. But at this point, because the numbers are relatively low and the cost benefit analysis hasn't been able to get to the point where we can just do more of a generalized screening. But I do think, as you say, as we improve our ability to work in the community to be part of what's happening. I think the genetics part, we are making some headway in getting more minorities into trials. And I think it's just now the momentum. We need the other major academic medical centers, investigators, to do what you're talking about and what you've done at Georgetown. Things that not as difficult at an HBCU like Meharry. We're working with Vanderbilt, and there's a lot of community engagement, and we're getting more minorities into studies. And
I mean,
so
to me,
it's just getting that momentum.
Yeah, I was going to say, to me, this is getting out the vote. If you want to be counted, if you want to be part of the answer, then you got to stand up and vote. And this, whether it's participation in clinical trials or other kinds of things, that's how you get your voice heard in healthcare. Craig, I'm going to let you take the last word, and I'm going to sort of reshape one of the questions we got around. This was around nutrition, but having an appreciation. We kind of touched on this earlier, appreciation for different cultural aspects to what we do. You talked about it being private. We talked about different diets that are culturally different. We need to do a better job in being sensitive to those things and figuring out how best to optimize a patient's outcome on the background of that. Would you agree with that?
Yes, I would. I would. And I can't, I can't stress how important, I know as we talked about this, is education and knowing the signs are different. Had I known, so after my sister was diagnosed, I took all the signs and put them in Google, and pancreatic cancer came up. So just being educated, that is so, so important. And that is what I spend the bulk of my time doing now with pancreatic cancer, just using social media, using those tools and those avenues, which I know we hang out in. Social media is huge. The church is huge, but just kind of starting from basic, knowing the signs, knowing when something is not right with your body, you go immediately and try to tell someone or find a way to get access to help. So that was huge for me. And I think that is big, education and knowing the signs of whatever that is going on. Something is not right with your body. You have to speak up. And that's something I think historically we haven't done a really good job of, is knowing something. It's like, oh yeah, that was hurting me a year ago. And here's a year later, whatever it is has progressed to something far worse than it would have been when you first got the sign and symptom had you gone and checked it out.
You all are awesome. To give up Saturday morning time is really double awesome. So thank you, Laura, Dwayne, and Craig. And we're going to close this session. Again, appreciate you all being there. And we're going to shift gears, and I'm going to hand the internet over to Dr. Marcus Noel, who's going to take us into our next session. Perfect segue to the facts and fiction around cancer clinical trials. Dr. Noel, good morning, and take it away from here.
Good morning, Dr. Marshall, and good morning, everyone. Thank you so much for joining us on this Saturday morning. We're excited to lead a session on fact and fiction around clinical trials. So I'm just going to start with introductions. So on our panel, so I'll start with myself. I'm Dr. Marcus Noel. I'm a GI medical oncologist by training. I focus on pancreatic cancer, but also treat all cancers within the GI tract. And I'm also the medical director of our clinical trials office here at MedStar Lombardi. So I'll start by introducing Jan Baird-Adams. Jan is a native Marylander and has lived and worked in the DC metro area for more than 35 years. A public librarian by profession, Jan holds a master's degree in library science and public administration. Diagnosed with pancreatic cancer in April 2021, she was privileged to participate in a clinical trial at Georgetown. Jan will celebrate 1 year cancer-free on December 15th, 2022. Jan is the proud mom of 2 adult sons, 1 grandson, and 1 granddog. She enjoys sharing books and information, thrifting, making jewelry, and is a self-proclaimed NPR nerd. Margo Michaels, introduce Margo Michaels. Margo brings over 25 years experience developing community-based education initiatives around clinical research, with a particular focus on improving clinical trials. recruitment among minority and medically underserved groups, and she has worked with the National Cancer Institute, the pharmaceutical industry, and patient advocacy. She is an independent consultant living in the Boston area. So I will turn over to Margo to lead our first segment.
Thank you. I don't know where my slides are, but I'm going to push. Can you guys hear me?
Yes, we can hear you.
Okay, great. So let me move along and let's see. And I know my camera is off, but at least I can move the slides along. So I'd like to start a little bit with some facts and common perceptions around clinical trials that a lot of people have. Can somebody help me get my slides up? I don't know why I can't see them.
I just received them now. I'll have them up in just a minute.
Okay, great, thank you. So I designed some of these questions because these are often the questions that I hear about clinical trials. It would be helpful for everybody to, can you guys hear me still?
Yes, thank you.
Okay, great. So I thought it would be helpful to go into some common questions that people have, common myths that people have around clinical trials, so that we can get a sense of where people are in the universe of the Zoom. And if you can, to please note your answers to the following questions. And then we will move forward together with a discussion. So, Marcus, you got the slides?
I think we're getting the slides pulled up.
Yeah, we may not have known about slides until this morning. Maybe we did, but we're trying to put them into the deck so everybody can see them.
Okay, great. So we want to try to make this a little participatory for people. And so these questions are true and false. And so hopefully we'll be able to help you take a look at them. And then we are going to continue with the panel talking about sort of physician perspectives and survivor patient perspectives around clinical trials. So let's see.
Perhaps what I can do.
We'll have them in just one moment here.
Okay.
Okay, you should be able to see your title slide right now.
Okay, great. Is it actually being shown? Can people see it?
Yes, we can see it.
Okay, great. All right, so let's start in the beginning. The first is it's important for us to just set a stage about what are clinical trials. And the first thing is that we have to start with the standard of care. And people know that when you go to your physician and you're starting to get treated for your cancer, your doctor is often presenting you a number of options for cancer treatment. And one of those, and several of them often, are the standard of care, meaning the best care that we know of for your particular condition, particular cancer. It's called standard therapy or best practice. And we know that certainly clinical trials are ways to find new types of standard treatment. And one of the ways that we see the progress in the kinds of treatment that we have is through looking at cancer survival. And certainly we're still not where we want to be, but if you look at what's happened since 1975 for two cancers in particular, colorectal cancers and pancreatic cancers, we're doing a lot better than we were in the 70s. And when my grandmother was diagnosed with colorectal cancer in 1975, there was a much different kind of treatment that was available, and certainly survival. So we can see that things are much different than they were, and we hope that through clinical trials, these numbers are going to continue to get better and better as the years go by. You guys can see my slides, right?
Yes, thank you.
Okay, great. So the first statement I'd like to ask you, and if you all can take a little piece of paper next to your computer and see what you think of this, is this true or false? Getting treated for cancer within a clinical trial is one way people can get high quality cancer care. Would you say that is true or false? I'll give you just a second to think about that. So the correct answer is true. And people are often surprised, some people are often surprised, maybe not on this call, about why that's true. And there's a number of reasons why it's true. Certainly, major medical bodies like the ones pictured here state that the therapies offered through clinical trials should actually be the first line, the first option for treatment. And one of the reasons for that is that these trials are designed by national experts often, or certainly experts in particular cancers. And the care that's provided through a clinical trial is high quality care because it's something called protocol driven, which means that it's driven by a particular set of procedures that needs to be implemented the same way for every single patient that's on a clinical trial. So people are often surprised about that. Let's move to the next question, which is true or false. Most people are eligible to participate in a clinical trial, but they decide not to once they're offered. So what would be your question, your statement to that? Was that true or false? And the answer is false. We know that actually all patients who are eligible are not offered clinical trials, sometimes for good reasons, sometimes not for great reasons. But we do know that when offered clinical trials, about half the people, or in some studies more than half the people, say yes, they would like to participate. And interestingly, we talked about healthcare and cancer disparities. We see that actually there's not very much difference between minority patients and white patients when we are offered clinical trials. We say yes at pretty much the same rates, which is interesting and sort of not what a lot of people think. So next, sorry about this picture, put it on. If someone cancer treatment, they're going to get a pill instead of appropriate treatment. We hear this a lot. So what would you say is the issue here? Is that true or false? And the answer is false. There is actually no way that a person who with cancer who is being treated on a clinical trial is not going to be provided appropriate treatment. They're never used instead of appropriate treatment. They may be used, of course, in a clinical trial, and you would certainly be aware of that possibility, but it's never used instead of appropriate treatment. That would be unethical. So people who say, well, I wouldn't want to be on a clinical trial, I've even heard primary care providers say, we wouldn't want to risk that. This is different than many clinical trials, and it's important for people to keep this in mind around cancer treatment trials, and it's an important myth to keep in mind. This last, one of the last questions is, who is appropriate for clinical trials? And many people say it's best for someone who has few or no treatment options left. So what would you say to that in terms of its accuracy? And that is not true. Clinical trials are not an option of a last resort. Receiving treatment in a clinical trial can be a high quality treatment option, even for a person who's just received a cancer diagnosis. And most patients participate in later phase trials. That's not to say that early phase trials aren't high quality treatment as well, but we certainly know a lot more about risks and side effects and efficacy once someone gets to participates in a phase 3 trial, which is the kind of trial that most cancer patients participate in. I could go into more background about that, but we're not going to have much time. So here's a multiple choice question for you, and I think you probably know the answer to this. When is the best time for someone to learn about the possibility of receiving treatment through a cancer clinical trial? Is it when they first get diagnosed and before they start making a decision about cancer treatment with their doctor? Is it when the doctor recommends trying a different approach because the treatment that they're on right now doesn't appear to be working? Is it only appropriate really when the doctor brings it up? Or is it just really A and B? So what would you say is the best time for a patient to receive treatment through a clinical trial? And actually, I can see that one of my answers didn't get put in here because it is actually actually it's A and B. It's really at all stages of cancer treatment decision-making, at first treatment, at second or third line treatment. It's really appropriate for someone to be exploring all their treatment options at all stages of your care, including even at the very beginning, because what we have found is even at the very first treatment, that if one doesn't think about clinical trials, one can actually preclude their ability to participate in the clinical trial at later stages. So I'm sure you have some questions for me, or maybe not. How many did you get right? I hope you got all of them right, or maybe not if you learned something from my presentation. We'll be glad to talk more after our panel is done, and I will turn it back over.
Thank you, Margo. Those were really great questions and thought-provoking. So I'll just speak briefly on the physician side regards to clinical trials, and then give the floor to Jan to share a little bit about her experience. So again, I'm a GI medical oncologist, and speaking globally from an oncologist standpoint, we view clinical trials as certainly an important opportunity to advance the field. The only way that new drugs are developed is by going through clinical trials and eventually receiving FDA approval. And so without patient participation in clinical trials, we're not able to advance the field. In addition, clinical trials can often potentially offer a therapy that is not otherwise available that could be beneficial to an individual patient. And so there could be a particular time where the physician feels that the clinical trial is actually the best treatment for a patient. As a very brief overview, clinical trials are typically, there are different types. There's phase 1 through phase 3. Phase 1 are the earliest phase trials where the typically the interventions are relatively new and being studied for the first time. Phase 3 are the later phase trials where that's typically the last step before FDA approval. And so as drugs move through phase 1 to phase 3, it can actually take 5, 7, 10 years, depending on the particular clinical trial. So it takes a long time to develop new drugs. And so each phase of a trial may offer different stipulations with regard to the trial. And so no trial is alike. And so it's important that you, when discussing a trial, considering a trial, speak with your physician about it to understand more about it, because each trial is very different, particularly based on the phase of the clinical trial. What I would also say is that, there is often can be reluctance to participate in a clinical trial from a patient standpoint because of fear, of mistrust, could be because of time commitment. The trial may require more time, may require more resources with regards to travel, et cetera. But there are times when the clinical trial is actually the best option for a patient. And so I would encourage all the patients out there to really be mindful of that. And when you hear the term clinical trial, don't immediately kind of push it off. Really embrace it, listen to what the doctor has to say, because that might be the best option for you. So, I think the most important part of this panel, and I'm looking forward to, is hearing our patients speak. So, Jan, I'll turn it over to you, and if when you're speaking questions come up, I may go ahead and ask them. But Jan, if you want to take over.
Okay, thank you. Yeah, so I was diagnosed with pancreatic cancer in April of 2021. And it was a very stressful and scary time. My mom had died from pancreatic cancer 6 years earlier. And I was just at my wit's end to try to figure out how to proceed. When I came to Georgetown and Dr. Noel became my oncologist, I peppered him with all kinds of questions. And in those early stages, I was looking all around the internet, and friends and people I didn't know were coming to me with all kinds of suggestions. And my late spouse was from the Caribbean, so I had all kinds of herbs being offered and potions and you name it. People were trying to help me, and I was trying to figure out what was the right thing to do. I have to say that Dr. Noel and his staff were just incredibly kind and patient with me. I asked questions over and over, and I got the answers over and over patiently each time. What was really great was that when he offered me this clinical trial, even though I didn't know exactly what it meant, it was a time when I said, oh, this may be the right thing. I want to try it. It turned out to be very good for me. It was, I was making my decision right in the midst of the height of the COVID crisis. And it's not lost on me as an African-American that our community has had a history of bad experiences with research and medical research. And a lot of people around me were questioning the COVID vaccines for the same reasons. And, it flickered through my mind that, okay, this is an experimental drug that, or process is being offered me, or treatment. But I didn't stay there. I moved forward and I accepted it. And I was amazed. I was treated with kid gloves. It felt like I was made to feel very special. From the research coordinator to the nurse practitioner, to Dr. Noel, to the nursing staff, everybody treated me very, very kindly and gave me a lot of attention to my care. When I had my first treatment, I remember that I watched the nurse hang the IV bag, and I hadn't realized that it was a blood product. And I was like, well, what is that? And I realized that was the drug that I was getting. And she reassured me. She gave me as much information as she had. I had information in writing. I had people answering my questions. It was a very good and positive experience. And my treatments were every 2 weeks. And each 2 weeks, when I came in for my visits and my pre-visits with Dr. Noel, and saw the progress I was making, I was just overjoyed. I was also really touched by how attentive he was personally to my case, almost making me feel like I was his only patient in some ways. I remember once when I used to email constantly. I remember once I got an email at 10:30 at night back from Dr. Noel. I was like, wow, he really cares about my situation and about my concerns. And it was great. It was great. So I come away from the situation, and now I am cancer-free. And I look back with amazement and gratitude, and I feel so blessed to have gone through the experience in the way that I did, to have the outcome that I did. I'm not saying it was easy. It was hard. It was hard to go through. But I had a lot of support from my family, my community, my friends. I had friendships that grew and deepened over the situation. My relationships with my family became closer over my situation. Even my employer showed such kindness in accommodating my needs during the situation. And I just came away feeling like, wow, to be at Georgetown, to be in the hands of Dr. Noel and his team was such a blessing. And I'm still amazed that I got chosen to be part of that and that I was blessed to have experienced it. And I just wanted to find any way I can to give back and encourage other people, people of color, and anybody who has an opportunity to take advantage, because these trials will, as Dr. Noel says, can result in drugs that will help people, many, many people through the years. And I'm just so pleased to have been a part. Thank you.
Thank you, Jen. I'd like to ask you a question, and you alluded to this when you started your presentation about you're diagnosed with cancer, and so your world is spinning, information is coming at you very, very quickly, and now you're considering a clinical trial, and you're balancing what the medical team is telling you based on what family and friends are telling you. And how do you balance that in terms of making a decision? You're respecting the physicians, but also what your friends and family have to input in terms of what you should do for your care.
Well, I was listening to everybody's input because I was very appreciative of the people who cared about me, cared enough to offer me input and advice. Ultimately, though, I kept my eyes on what you, Dr. Noel, and your team were advising. And you can remember that I would come to you and I would say, oh, this person brought me some pine bark to make tea out of, or this person told me to eat this or that herb. What do you think? And I always ran it by you because I also respected that my friends and family were telling me things that they believed in. But ultimately, I knew that my care needed to be guided by your expertise and the expertise of the medical community. And that's what I relied on.
Thank you. And yes, during the last 2.5, 3 years, we've, as a nation, as a world, through the pandemic, learned so much about clinical trials and research. And in this country, dating back years to the Tuskegee experiment and Henrietta Lacks, et cetera, there was certainly research practices that were not correct, were not right, and people were taken advantage of for a number of years. And I remember, having conversations with my grandfather even before going to medical school about things that would happen, perspective as a Black male. But I will say that I'm often sometimes surprised by, some of the younger generation, like people in their, under, let's say 40 or 50, where they have so much fear and mistrust for the healthcare system around research and clinical trials. And I can understand it for those who were closer to what happened in this country in the early part of the century. But I'm struck by how this message is pervasive now in 2022, and the pandemic and vaccinations just bring it to the forefront of people's mistrust. And so as oncologists, as physicians, researchers, we struggle with this, and we try to do our best to demystify clinical trials and demystify research, because our goal is to advance the field. Our goal is to help the patients that we have in front of us, but also those who may come in the future. And it's work that's being now that's going to help those that are coming 10, 20 years from now, with the overarching goal of reducing the burden of cancer, and for those who are affected by cancer, improving their outcomes and improving their survival. At Georgetown, we participated in a clinical trial in liver cancer and cholangiocarcinoma, led by one of my colleagues, Dr. He. And we this for years, the standard of care has been to have treatment with chemotherapy, 2 chemotherapy drugs. And just this year, there's an FDA approval for immunotherapy in bile duct cancer. And it's amazing to see this. And now I have patients in clinic who are benefiting from this drug based on the clinical trial. So patients who were treated on the clinical trial previously, who some of now have passed away, has led to patients that are currently this day receiving treatment and living longer because of that treatment. And so that's just so awesome to see the work that's being done now that's going to impact those in the future. And Margo, you made a great point earlier with the question and answers in terms of many patients are actually perhaps not eligible, but if they are eligible, and offered a trial, they often will say yes. And maybe Margo, could you speak a little bit about what kind of things could be done in the medical community on the researcher side about making sure that more patients are eligible for clinical trials, and also what can be done so that patients who are eligible are offered trials? What can physicians, practitioners do to make sure we offer trials to all of the patients who are eligible?
Thanks, Dr. Noel. So a couple of things. One is that we know that clinical trial eligibility is an issue, right? The way that trials are designed often doesn't allow everyone who would like to participate in a clinical trial. And there are a lot of minds bigger than mine, perhaps even bigger than Dr. Marshall's and Dr. Noel's, are working on ways to expand the kinds of criteria researchers use to make sure that someone can be on a clinical trial. So that's something that's happening and that's expanding now, which is very good, for all of us to make sure that we're using criteria that make sense rather than just what we've always used before. My second point around sort of who is offered clinical trial participation, there's 2 ways really that this happens. One is that doctors need to take a look at patients who could be eligible in a systematic way, so that, Dr. Noel has 10 patients coming in this week, and before they come in, Dr. Noel, I'm sure, is looking at, and his staff is looking at, wow, this person looks like they may be eligible. I need to make sure to keep this in mind when I talk about treatment options for that person. And that needs to happen universally, where we make sure that everybody who we are seeing for treatment decisions are being screened to see if they're eligible for a clinical trial that we're offering. And sometimes that's not happening as much as it should. And we know that sometimes, docs don't have the infrastructure in place to offer a clinical trial, but in the places where, like Georgetown and other large cancer treating facilities where they offer clinical trials, we want to make sure that every eligible patient is offered that opportunity. It's not right for everyone, certainly. And certainly patients go through an informed consent process and an education process. Maybe Jan can talk a little bit more about that, where they learn about all that's going to happen in a clinical trial and make an informed decision to participate. But we want to make sure that everybody who is eligible is offered. And if you're not offered a clinical trial, not to assume that, well, it wasn't right for me. That may or may not be the case. And so I would encourage every patient to say, hey, doc, is there a trial that's right for me? If not right now, when we think about that? Because you as a patient, all of us need to be active, not only assuming our doc is going to offer us everything that is eligible, but also that we're eligible for, but also that our doc knows that we are interested, perhaps in the possibility of participating. So, Dr. Noel, I'm not sure if I answered your question, but
yes, you did. Thank you. Jen, I have another question that just came to mind. With clinical trials, sometimes there is a requirement for either more visits or longer time where you're at the center receiving treatment, and patients may have to ask others to help them, whether it's friends or family. And, depending on the patient, they may be, some patients just prefer not to ask others, but I always encourage my patients and tell them that now is the time to, people are going to want to reach out and help. Now is the time to accept that help. And Jen, can you speak a little bit about how you handled that in terms of having support from your particularly like your son and other family and friends to help you get back and forth for your treatments?
Yeah, so I did have an awesome network of friends and family. A few years before, I had lost my spouse and my dad within a month of each other, and I kind of rejected everybody who reached out to me. But when I found out I had pancreatic cancer, I did just the opposite, and I told everyone, and the help came pouring in. I had a friend who made a spreadsheet, who sent out emails for rides. I mean, I was perfectly capable of driving myself to Georgetown, but I didn't want to do that. I felt like I was in no state to do that. And I wanted to have somebody with me. It was during COVID, so I couldn't have anybody with me during my treatments, but I could have friends and family take me to the hospital, bring me home. As I said, my employer was very kind. Because of the clinical trial, my treatment days were often 10 hours long, between my medical visit with the doctor and his team first thing in the morning, and then an 8-hour regimen of treatments and chemo. It was a long and grueling process. And then to have somebody else pick me up, bring me home. My son, who lives in New York, would come, and he was working remotely. So on my chemo weeks, he would just come and move back into my dining room table and work from there and be available and make food for me. And just, it was amazing. And there were so many people praying for me, and I felt so blessed through the process, because several of the people who gave me rides I'd been in a book group, a local community book group with for years, but I didn't really know them well. And now I have these really good friendships that have developed, and a closeness with my brother even, who lives in Baltimore, who would come down and give me rides and do things and take care of me, and who took care of me when I got out of the hospital. For 3 months, I stayed at this house. I just allowing myself to open up and accept the help made such a difference in my experience, I think. In the earlier session where someone talked about how sometimes in the Black community, these diagnoses are kept a secret because you feel like you've done something wrong to cause you to be sick. When I did the opposite and opened up, I was just overwhelmed and blessed by the response of my family and friends.
Thank you, Jan. I'm going to address a couple of questions now. I see, so one question in the chat with regards to 5FU, which is one of the chemo backbones. Jan actually received 5FU for many of our GI cancers and has been around since the 1950s. So in terms of what's being done to further the field, so in colorectal cancer, yes, 5FU does remain a backbone because the drug actually works really well. But what we're doing is we are using molecular profiling, and this is an important point. So what we do for all of our patients with cancers is we will take a sample of their cancer and we'll run it for genetic analysis to determine what mutations are present, because there are some mutations that are what we call actionable or driver mutations. These are the mutations that can actually turn the cancer on. And so if we can target those mutations and halt and arrest growth, we can see improvements in cancer outcomes. And so in colon cancer, for example, although 5FU is still utilized, clinical trials have added on new drugs to 5FU. So you have bevacizumab or Avastin, which has been around for 20 plus years now. You have EGFR inhibitors, so specific targeted drugs for specific types of colon cancer. You have immunotherapy for certain specific type of colon cancer as well. So these are being combined with 5FU to improve patient outcome. In addition, and we had a scientific session on Thursday, we are understanding more about location in the colon and the fact that right-sided colon cancer behaves differently than left-sided colon cancer. And so even though 5FU is utilized for both sides, we can pair the 5FU with targeted therapy that may be different based on where the cancer originates. And so certain drugs work better on the right side versus the left side. And so going back and looking at the data from previous trials, researchers have been able to understand this phenomenon and then build on that to design trials in the future. Another question that was in the chat is, if a patient is not offered a clinical trial, or if the oncologist does not mention it, should the patient assume that a trial is not an option? Margo, do you want to take that question?
Yes. I think that that should not be assumed. That may well be the case, but it may not be the case. There's a lot of good reasons why your doc may feel it's not appropriate for you, but it also may be that your doc doesn't know about all the trials that are available either at their site or at local sites. Sometimes it's possible that where I live in Boston, that there might be a trial going on at X place. It's not going on at Y place, and the trial in X place may actually be appropriate for that person. So, docs don't know everything that's happening everywhere, and so that's why you also are your best advocate. My uncle, I remember him saying to me, well, if it were appropriate, my doctor would have mentioned it, and since he didn't, then I'm not going to say anything. And I think that's we should not. I wish my uncle hadn't done that. I wish he had thought to ask more from his doc and perhaps to find more available.
Thank you, Margo. So I'm going to address a question on, I mentioned this earlier. So clinical trials often have very strict inclusion criteria. The reason for this is that in order to, when designing a trial, you want to make sure that the drug that's being tested has the best chance to succeed. And so typically the healthiest patients are allowed to participate, but those who are borderline are excluded. And so this is at the level of the NCI and researchers across the country, this is a big issue because we want to be more inclusive with our clinical trials. We want our clinical trial data to mirror that of the general population. And so some things that are being done in clinical trial design are, for example, oftentimes HIV patients are excluded from trials for cancer trials without a really good reason. Many of the drugs that we give, there's not really a direct interaction with antiretroviral drugs, but because HIV patients were excluded in the past, they're excluded now. And so what we're doing is actually taking away that exclusion. So only if it is absolutely critical that a patient not be included if they have HIV, they are now permitted to enroll. Another example is kidney function, particularly in the African American community, where kidney function may be compromised. We are loosening at times our strict inclusion criteria for kidney function so that patients who perhaps have worsening kidney function can still enroll. Same being for diabetes, hypertension, critical for the drug, where it's going to be a safety issue. We would allow those patients to enroll. Another big issue in terms of access is so patients understanding that patients have to make a sacrifice to come in for their trial, and some trials are very strict with biopsy requirements or coming in for visits on 3 or 4 days a week. And so we're trying to design trials now where they don't have to, patients don't have to come in as frequently, because we know that in itself can be a barrier for enrollment. And so if we can minimize visits and minimize time in the infusion center, that will hopefully allow more patients to participate. And so like trials that I'm designing or that we are designing where we have full control over design, we are only requiring people to come in if it's absolutely necessary to come in. And in fact, now in the era of telehealth, there are some trials that will allow visits to be done remotely so that patients can actually just do the visit right from home and only come in when it's needed for either blood work or treatment.
I'm wondering how many people got my questions right. I hope that you all got some right, or that you even got none right and learned something from the true and false questions we gave at the beginning.
So there's a very important question, and I'm sorry I didn't address this earlier, about for patients, what is the best way to find out about clinical trials, or what's the best way to access clinical trials? So there is a website. So any trial that is registered worldwide has to be registered on clinicaltrials.gov, clinicaltrials.gov. So this is a website that houses all the clinical trials. It can be a bit busy and difficult to navigate, but you can go into that website and then you can narrow down your search criteria to your specific diagnosis. You'll often need to know the stage of your cancer. So if you have stage 4 colon cancer, you'll want to limit it to stage 4, and then you'll want to click open and enrolling trials, because it may list trials that are going to be open in the future or were previously open but now closed. You want to focus on the ones that are open and enrolling, and through that site you can kind of scroll through and see what trials are open. Each trial will list the location of where the trial is enrolling, and you can then call that site for more information. So clinicaltrials.gov is a very helpful website. In addition, there are a number of patient advocacy groups that also can help. For example, today, this is Pancreatic Cancer Awareness Month being November. We have our purple on today. So PanCan, the Pancreatic Cancer Action Network, is a great organization that is one of their main focuses is guiding people towards clinical trials. And so the Pancreatic Cancer Action Network, PanCan, can be helpful in finding trials. There, each GI cancer, there's the Colorectal Cancer Alliance, there's the Cholangiocarcinoma Foundation. So there are many advocacy groups that are you can contact, and they will help you to be able to navigate what trials may be available for your particular disease. And Margo, you have your hand up?
Yeah, I just wanted to say that the National Cancer Institute 1-800-4-CANCER has a national hotline to search clinical trials for patients. Dr. Noel's mention of the clinicaltrials.gov website is clunky. It's hard for a lot of people to get through. So speaking to a person who can help you search can be easier for some people rather than searching through a large database.
So we're coming down to our last minute. There was a question for someone wanted me to expand more on colorectal cancer. So right-sided versus left-sided, what the data would suggest is that the outcomes tend to be a bit worse for right-sided colon cancer. And there is a mutation called EGFR, epidermal growth factor receptor, and so that we have targeted drugs for this mutation. So we test all of our patients with advanced colon cancer for this mutation, and for those patients who have a normal gene, they benefit from an inhibitor of that. So it's called cetuximab or panitumumab. On the left side, we think of that drug as being very useful. So left-sided colon cancer patients typically will receive an EGFR inhibitor, whereas right-sided colon cancer patients, even if they have a normal gene, will often give them a drug called bevacizumab, which is a drug that helps to prevent new blood vessel formation and limit cancer spread. We give those patients bevacizumab treatment regardless of their EGFR mutation. So right-sided colon cancer, we give a combination of 5-FU and other drugs plus bevacizumab. Left-sided colon cancer, we typically give the chemotherapy plus an EGFR inhibitor if their mutations are appropriate for that. And the last thing I'll say is regarding immunotherapy. Immunotherapy is a mechanism where we give a drug to stimulate the body's immune system to attack cancer. And this has been a breakthrough for a number of cancers. And finally, we're seeing this in the GI cancer space, including liver cancer, esophageal cancer, colorectal cancer. And so we are opening up clinical trials looking at immunotherapy in pancreatic cancer as well, not only here, but at Hopkins and other centers across the country. And so certainly, please reach out to your physicians to make sure you're asking about trials with immunotherapy.
You all are awesome. I need to jump in and let our last session get their time as allotted and to move on. But thank you, all three of you, for the contributions you have made to today and in the world in general. So we're very, very grateful. And it's particularly giving up Saturday time is tough. And I know you all have done that. And so get back to family and we will get on with our last and final session around GI cancer survivorship. This is last, but absolutely not least. This is a critical element to anyone going through the journey of cancer treatment, cancer survivorship. And I'm very grateful for Martha Raymond, who is, I mentioned earlier, is the executive director of the GI Cancers Alliance and the founder of the Raymond Foundation. She is going to host and moderate our final session of the 13th annual Ruesch Symposium. So Martha, the internet is yours.
Great. Thank you, Dr. Marshall. It's just a pleasure to be here. And thank you to everybody at the Ruesch Center. Just an incredible two-day symposium as usual. So thank you so much. I'm so pleased today to have the opportunity to speak with Dr. Nina Caden-Loddick. She's a pediatric hematologist oncologist who is professor of oncology and pediatrics, the director of the Survivorship Research Initiative, and the principal investigator of Children's Oncology Group clinical trials at Georgetown University, MedStar Hospital, and the Lombardi Comprehensive Cancer Center. Her research, with over 95 publications, focuses on improving the medical, cognitive, and psychosocial long-term outcomes in children, adolescents, and adults with cancer across the lifespan. She's the principal investigator of 2 multi-site randomized control trials funded by the National Cancer Institute to improve physical activity and adherence to recommended surveillance for late complications of therapy in cancer survivors. So with that, Dr. Caden, I welcome you and I look forward to our conversation. I guess I'd like to get started. If you could give us a little bit of information about the Survivorship Research Initiative at Georgetown.
Absolutely. And I just want to say how happy I am to be here with you and with all of our attendees. This is just a wonderful symposium. So I was really delighted to come to Georgetown to take the leadership of the Survivorship Initiative. And our mission is to improve the cancer experience at every stage of the cancer journey. And a critical part of it is to get the best therapy at the right time. But there are also other components that are very important to make the best of what's a really challenging situation. They have to do with optimizing quality of life at every step. And that's at diagnosis, during treatment, and then afterwards. And so you're really a survivor from that first moment. And I will also add to that definition, improving outcomes for all the people impacted by the cancer diagnosis, which also includes loved ones, caregivers, and trying to optimize that experience too. And that means advocacy, like your wonderful work, and spreading the word. It means doing research to know what our best practice is and what works. And it also means making sure what we learn is incorporated in how we do clinical medicine and having those components. And that's something we take a lot of pride in at Georgetown.
Absolutely. And that was going right into my next question of how the research and the wonderful important work that you do with this initiative translates to the clinic, and then from the clinic, obviously, to the patient and the caregiver.
So I think for me, it's very important that I'm a physician scientist and I still take care of patients, and our patients, like the ones who are attending today, tell us what's important and what's more challenging, or what's higher priority, or what things get missed. And that informs our research and what priorities we have. But then when we do learn things, so for example, we have understood very carefully now that, we need to communicate better at the time of diagnosis what to expect at different steps along the journey. And we are trying to build tools to do that. We spread the word with physicians. We have made our teams more multidisciplinary, where there are physicians as well as nurses who help, and social workers and others, and patient navigators who help us with that role. So that would be one example of how research has informed how we do medicine, because years ago we wouldn't have had all those members of the team as involved. So that maybe that's a very concrete example, but that becomes the new standard of care and best practice. And I'm hoping that taking care of yourself and starting your rehab for cancer during therapy becomes part of practice, because we're learning more and more that health behaviors, like even walking more during therapy, even when you are fatigued, help with decreasing nausea, decreasing cognitive problems and memory problems during therapy, and mood, and that can decrease the risk of having problems in your heart and your lungs and your bones after therapy. So one of the things my research is trying to show is how we can do that, and how we can find out just what's the best way to do it, and and how can we, and just how much benefit are we getting for each of those things. And we've done it after therapy, but I'd really like to move during therapy, because I think that is our opportunity to get the most benefit.
That's, and I agree for sure. And, one thing I would say, just by a snippet of my background, being a patient advocate for about 35 years now, so I'm dating myself, but that's okay. I started because both my parents passed from colon cancer, early age onset, before we even knew what early age onset colon cancer was in the 1970s and early 1980s. They were very young, I was very young, and there were no resources, there weren't resources for patients, and there really wasn't anything for the family, for the caregivers. And so I kind of changed the whole direction of my life. I was in college when my mom passed, and I thought, okay, if I can do something to help, so to pay it forward so other families don't have to go through this alone. And then fast forward, 35 years later. But that's why I think survivorship, it's a very broad term, obviously. So I know in this half an hour, we won't be able to get to everything, but I think it's just so important for those of us that are survivors that we understand that there is this work being done, and one of the things that I have spent a lot of time in my career on is researching patient-reported outcomes. And it's just so meaningful because we learn from individuals that have really walked that walk. And one question I had is, are there specific ways that survivors and caregivers can get involved in, say, the initiative at Georgetown?
Most definitely. So I think that one of the ways is to go to one of the survivorship clinics. So there are survivorship clinics in both at MedStar Georgetown and MedStar Hospital Center. And I think that, and in that clinic, there is a focus on after therapy, how one can both best optimize your health and well-being and rehab from the cancer physically, and also make the best life health behavior modifications so that you can stay as healthy as possible. And then also know what should your checkups look like, because your checkups after having a cancer diagnosis will look different. And this is separate from tumor recurrence monitoring, which should happen. And that's very important, but this is also separate from that. There are other types of checkups, because getting that curative therapy means that there are unintended consequences too. It's a very strong experience on your body, and it's important to make sure your heart and kidneys and other parts of your body are doing well. So there's those kind of checkups. So that's one thing. I think another thing is to just know that that life can be good and the quality of life can be good, whether you're living with cancer or have finished therapy with cancer, and that you get whatever support you need to optimize your quality of life. And so there are resources for optimizing your coping and your mental health through the Smith Center, which is a wonderful organization in our community. There's also your own docs and nurses who care very deeply about you to share with them if there are parts of your life that are impacted, so they can refer you to it, whether it's a pain in a certain area or whether it's trouble with sexual intimacy. It's just really important to share this with your care team, because they know of this is a common thing people experience, and they know of ways to help you, and they can connect you.
Yes. And I think too that if there are individuals, I know we have people from all over the country with us today. And as you mentioned, Smith Center here in the DC area, also Hope Connections for Cancer Support, they do wonderful work. But I think if there are people that are, outside the DC metro area, there are so many wonderful national advocacy groups, very thankfully. And I know we've mentioned a few of those today, but, groups like Colorectal Cancer Alliance or PanCan, Cholangiocarcinoma Foundation, and many others. GI Cancers Alliance, if there are people listening and you don't know of a place in your community, please reach out, because we do that all the time. I always talk to patients every day and help find them, resources in their own communities, or online groups too. I think, not that there was really any bright spot of our pandemic, but I do think one thing for patients was that they learned that they can get support online through online groups and chat forums and things like that. So it doesn't make up for the loss of being together, but it at least is something to maybe bridge that gap until we can all be together, in person for different events. One thing I would ask as well is, again, in survivorship, we often hear of, especially in GI cancers, so many of the physical side effects, whether you're in treatment or you're post-treatment. And those, of course, are, can be very severe in GI cancers. But then, kind of the emotional, psychosocial, and I know you just touched on that, but it's kind of the invisible scars that we may not see and may not, for for people, even family, understand what a patient survivor is going through. Are there any things that you would, let our audience know that we might look for or be able to help our loved ones as they're going through, concerns?
So I guess I think it's very important to normalize it. I think that we use a lot of words related to cancer that can make it hard for someone to admit when they're not doing as well. We use words like fight hard, or we say this is an episode and now we're done, and then you feel bad to say, I'm still not right. And I think it's just I would like everyone to know that it is very common, and many people experience sadness, very high stress levels, sometimes even guilt because of how they're doing compared to other people, or guilt that they wish they had done something different there, and then being triggered by aspects of things that remind them of their cancer experience. So that can be impairing, so that and I want to say, even though people don't talk about it because there's so many sayings about being strong related to cancer, that it's very important to know that as a physician, many people, and I think it's actually slightly the majority, more than 50%, are struggling with these things, and that makes a lot of sense, because this is a life-altering experience, and it's okay to ask for help, and that help is here, and these things, and people feel better when they get help. And maybe that's an obvious thing to say, but I think that's very important, because those studies have been done, and people who have gone through cancer experiences or are going through cancer experiences do better when they get support, whether it's counseling, whether it's peer, like what do you call it, support groups, whether sometimes it's medicine to help take the edge off the strong emotions, whether it's changing your setting or changing your life direction, so you set yourself in your life in a way that is a better balance for you. So I guess that's what I'd say. I would say that you deserve it, that it's common, and that you can still be a strong person, or someone who is doing well and yet need help in these areas.
Yes, exactly. And, and one thing I would say, just too, from personal experience, next year it will mark my 20-year survivorship. And I have to say,
congratulations.
Thank you. But, even after all this time, very blessed, very grateful. But even after all this time, each year when I go in for my MRIs or my CAT scans or my colonoscopies and, endoscopies, it's very nerve-wracking. And you often hear survivors, patients talk about scanxiety, when it's that anxiety of going for those scans. It's very real. And I think that if it's 1 year past treatment, or 20 years or 25 years, I think that will always be there. And I like when I lead my support groups, I always say, to me, I look at it like cancer, it will change you, but it can be a chapter in your life. It does not have to be the whole book. And your chapters will, you'll grow and you will change. But as you just said so beautifully, that we can go on to do important work and find ways to kind of cope and bring that anxiety, to be able to learn to live with that a little bit. It's not always easy. And like I said, we all struggle with that, but thankfully now we do have organizations and places we can go for that support.
Absolutely. I've even heard people say, oh, I'm really anxious and depressed, but because of the cancer experience, that's just the way it's supposed to be. So I also want to say, for people who are getting therapy, that you're not that just in the same way we try to treat nausea or treat pain, that also even during the cancer experience, you deserve to get the support and treatment and feel better, and you can feel better even through a difficult situation to help. I mean, of course, it'll still be a challenging situation, but you can help feel more up to the coping and find ways to feel more in control of all that. So before and after, and we're talking a lot about the emotions. I also want to say it's also true for a lot of the physical things. So people can have chronic pain, or they can have problems with intimacy, or problems with tolerating certain foods, or you can even have problems with your teeth. Chemo can even affect teeth and make it more fragile. And for some of these things, or most of these things, actually, we have therapies that help. So I also would like to just emphasize that it's something that is that's what our survivorship research is about, is how we have built a armamentarium of ways to help intervene and change the trajectory of that, and not just be having to say that's an immovable cost of therapy. And I saw one question in the box about or in the chat about, have we started considering that in our clinical trials? And absolutely have, because the idea is we know nothing in life is free, and that there's never anything that's all good. There's always a balance. So we're always trying to balance doing more good. So we try very hard in our clinical trials to try to increase cure and disease response with the least amount of toxicity. So there have been replacements of different therapies over time. We try to reduce radiation dose whenever we can, when we can do it without optimizing cure in different clinical protocols, or how frequently we give doses. So when we can do it, that is also another area of survivorship research that we do paired with therapeutic doctors, is saying what can be eliminated, or what agents can be replaced that have a better toxicity profile. And we're very actively thinking about that. And I'm very gratified that when you go on a clinical trial now, when you say patient-reported outcomes, we didn't used to ask patients how they felt. We only decided if something was a winner based on how the imaging looked or whatever the blood marker. And now we ask patients how and how their experiences during the therapy is part of the equation about how to gauge the worth of the benefits of a certain treatment approach.
Yes. And I agree 100%. And I think especially too with as we mentioned with our GI cancers, so many of the physical side effects, they don't necessarily go away after, maybe after treatment ends. And so, for lack of a better phrase right now on a Saturday afternoon, using the new normal, which I know many people maybe don't like that term, but for lack of a better one at the moment. But I do think that it's important for all of us to understand that, if you're a gastric cancer patient, if you're, stomach cancer, it may be difficult. You're not able necessarily to go out and eat or have fun or go to a game and have, food like you normally would. And what I've learned in a lot of my research with patients is that takes a toll, obviously physically, because you're not able to enjoy the things maybe you once did. But then also it's that emotional aspect of, you're feeling like you can't be that person you used to be. So I do think so many times that goes hand in hand, the physical and then the ramifications of, okay, and now this is another aspect where I can't be the whole person I was before.
Oh, I could totally get that. And I think that that's important to acknowledge and work through. I have another analogy I sometimes think of for what the cancer journey is like. I had told you, I think of it a bit like travel, like you are planning to go to France. I don't know, I'm going to name France because, as you know, my son is doing his semester abroad and there, so that comes to mind. And your trip was planned to go to France, and now the plane is not going to France. Let's say it's going to Britain. And can you still have a good time and have a good life? And it's not what you're expecting, and there's going to be differences, and there will be things you're giving up, but I'm hoping there are things you'll gain, depending on how you're setting yourself up and deciding and getting your mind ready for a different place. You can have a good life, you can have a good journey, but it's going to be different. And yes, I'm going to say food is hard, because we know food in our lives has to do with it symbolizes social connection, and it symbolizes, and it's a sensory pleasure. There's a lot of but this is also where thinking about going into, that doesn't mean there cannot be social connection, and that there cannot be sensory pleasures in life, and maybe it'll be something given up, but
right.
But
and I agree 100%. And again, what I always chat about with patient groups is that yes, it will be different, but exactly like you said, you can make it work. And even now for me, when I travel, I know I need to take XYZ food with me. So I know I always have something, because there's so many things I can't eat. Or I know I need to prepare ahead of time if I'm going to someone's home, for a holiday or things like that, because I think the more we can control in a situation that's, obviously cancer is out of our control. And I think that's one of the things that is so frightening for so many patients. But if we can control some of these other things, I think that does it. It empowers us to say, okay, I got this. And, I'm flying to San Francisco, but I'm going to be okay, because I know I have what I need, just in case there aren't things available at my hotel or wherever that might be.
That's great thinking, great strategizing, and you take control of it, not relying on it being there for you, and knowing that it's worth it, that you're worth it to do that. I think that's all very important. I want to also allude to what you were saying earlier about you're losing your parents and having having them diagnosed with colon cancer early in life, and how for advocacy, I think another part of survivorship is having the knowledge you need to make healthy decisions. So part of that may be, I've talked about, my research has to do with physical activity and showing that even a little extra physical activity goes a really long way. But there are other things which have to do with getting genetic counseling, so that you can find out for yourself what other things personally you could be at risk for, and how to screen for them early, so they can be, hopefully you will never get them, but if they were presenting, that they would be found at a point when it was early enough to have the best outcome, and also so that you can know what family members need to think about. And I'm sure your parents, if the knowledge were there, they would have wanted you to have that. And that's a big part of survivorship too. It's about optimizing your health and well-being, given that somehow someone threw you into this cancer experience. But
right, I couldn't agree more. And I think, like I said, back in the 1970s when my dad passed, and then early 1980s when my mom passed, we didn't have that science. The science wasn't there, but thankfully now it is. And again, just as a personal nugget, I knew that I needed to start, screening and had my genetic testing. I have a daughter. She started her colonoscopies. We'd go mother-daughter day. We still do for our endoscopy and colonoscopy. And she's had her testing. So it's just, again, not to use a coined phrase, but that knowledge is power, because you can take control, and especially for family members. I mean, to give them that, which wasn't available a generation ago, I think is so important, and agree that is a huge part of survivorship, and paying it forward through that advocacy. And one thing I was going to say too, and I know we only have about 4 or 5 minutes left, but today, listening to Jan and Craig Irving on the first panel, just incredible. And again, how both of them are paying it forward, and they're helping countless people. They may not even know who they'll touch with their stories and their bravery for speaking out. So I always encourage, survivors that, they'll know when the time is right. They'll know when they say, okay, I want to do something. And no act is too small. Some people think, oh, if I can't raise $1 million, it's not going to make a difference. But that's so not true. It's one act, helping one person at a time, is just as important. So, and again, I think that's just another huge part of survivorship, is that advocacy piece.
It is. It's a way of taking control of your narrative, and right. Instead of having it only be something that happened to you, it's something that you transformed. I don't know if anyone earlier today has yet talked about post-traumatic growth. We talk about post-traumatic stress after a horrible experience, but one of the things that we realized in cancer patients is that many of them experience post-traumatic growth, which is that this awful experience transforms you so that life has more meaning, that there's a greater appreciation for life, there's a greater appreciation for our relationships with others, or there's a better appreciation for how we want to spend our time, so life has meaning. And I think advocacy definitely is a part of that. It's saying, I'm so sorry this happened to me, but I can turn it into something good. I'm not going to have it. I'm going to control the narrative. It's not going to be all awful. Part of it is that I'm now in a position that I can maybe say a kind word, or be a patient advocate. And as a researcher, I'm going to say, as an advocate that can help be a stakeholder that gives advice about this study could be more doable if we did it this way instead of that way. And that's another role that we find very important for survivors, because we want our research to be driven and done in a way that we know is going to work and that matters to the people. So that's another way. Another way is to lend your voice to people going through the experience and help them cope. So many ways. Exactly.
Beautifully said. Thank you, Dr. Lodick. I think we're just about out of time, but I would like to say, for any patients, caregivers, survivors, please, if you're looking for resources, I know the Ruesch Center, they have amazing resources to help. GI Cancers Alliance, you can reach out to us for specific advocacy organizations. If it's esophageal cancer, gastric, colorectal, all of the GI cancers, we can get you the information you need so that you're not alone. I think that's the most important thing, that we're all in this together, and we will find you the resources you need. So, Dr. Lodick, I just appreciate your time so much today. And, with that, I'll turn it back over to Dr. Marshall. But again, thank you so much. Wonderful conversation.
Thank you. Thanks so much. And I feel very honored to be part of this wonderful program.
You're great.
Thank you.
Thank you, both of you, Martha and Nina. Thank you so much for for participating. And I want to express my thanks to all of those who continue to be logged in. We've had quite a nice big crowd this morning. We do want to get to, there was somebody asked about the Smith Center. That's the smithcenter.org is their email site. And we have our contact information here for the Ruesch Center. And so on behalf of our partners at OncLive, on the whole Ruesch Center team, the GI Cancers Alliance, we're very grateful for all that they have done to help us put together our programming over the last few days. I officially now declare it the weekend. And so people can go off and do the things that they've been putting off to kind of catch up for the week ahead. And a busy week it will be, with hopefully getting together with family and friends and being thankful for what is another day. And I hope your days ahead are joyful. One of the ways I have been trying to get through the pandemic and our own personal stresses is every day finding something that brings me joy. And I have to say, this morning's discussions and participation with you all, I already got mine in the book for today. You all have brought me a great deal of joy as we've shared our thoughts around trying to find more cures for patients with GI cancer. So on behalf of the entire team, I want to say thank you and have a good rest of your weekend.